understand that we have colleagues. Yes, I understand that we have colleagues from Malawi, colleagues from Uganda, some parts of Southern Africa, Lesotho, and many other, including Tanzanians and Kenyans and Ugandans, East Africans. This is an important opportunity that we are welcoming all of us to really join at this hour. So without wasting much of time, I'll welcome you, Bill. You know, me and you as organizers and trusted colleagues who have been appointed by our two foundations. We ran this course. This has been a year and something. And we have been running the course for hand surgery to general surgeons. Today will be likely a fourth lecture. I welcome you to introduce our visitor, and from there, Dr. Scott will take over. You're welcome, Dean.
Okay, Mugisha, thank you very much, and good evening to everybody. As Mugisha mentioned, we're in the middle of a course entitled Hand Surgery for General Surgeons, and my friend Dr. Scott Hansen, who's going to talk to us today about hand injuries, actually played a big role behind the scenes because he's an expert hand surgeon, and he helped me arrange all the lectures that you've heard so far. Remember, we've talked extensively about hand anatomy. We've talked about evaluation of the hand. We've talked about flexor tendon injuries last week, and so right now Scott is available, and so I thought we would. He's a very experienced hand surgeon, and many of you who are practicing in district hospitals as general surgeons, you have to manage all sorts of hand injuries, including hand fractures. So Scott, who is a professor of surgery at the University of California, San Francisco, is going to talk to us about the management of hand fractures. And without further ado, I'll turn it over to Scott.
All right, well, thank you, Bill and Mugisha. It's nice to be here, and it's really an honor. And I'm going to share my slides, and let's see if everybody sees do you see my slides, Bill?
Yes, it's loading.
Thank you. Okay, great. And so this is obviously this is a big topic, and I welcome anybody to stop me at any time to ask any questions. I think if I brush over a concept too quickly, I try to keep this talk, something that things that you'll see commonly to treat with hand fractures of the hand, and at any point we can always stop and talk, and then I can cover other items later if needed. So again, it's truly an honor to be here with everybody today. This is a talk that partially is from the American Society for Surgery of the Hand, a talk that a bunch of hand surgeons put together to give overviews of different topics, this being hand fractures. So today we'll talk about phalangeal metacarpal fractures and fractures of the carpus. And so my goal, I think, I'm going to work distally in the fingertip and then move proximally into the carpus. And again, we'll see how far we can get today with the amount of time that we have. And please stop me should you have any questions. As I'm sure Dr. Schechter's already covered with you in your hand lectures, everything in the hand world revolves around the history of any type of hand injury, specifically with regard to fractures, the age of the patient, their handedness, right or left hand, their occupation, the past medical history, the mechanism of the injury and what happened, histories of previous injuries or treatment to the hand, and their tetanus vaccination status. Like every other area in surgery and medicine, evaluation, physical exam is very important, and the hand is no different. And there is no one way to examine the hand perfectly, but I think you pick your method and you stick with it. And some talk about starting with the nail bed and then moving proximally. So the skin, nail bed integrity, neurologic evaluation, light touch, 2-point discrimination. And some of these mutilating hand, we're talking about hand fractures today, but oftentimes hand fractures are accompanied by soft tissue injuries, as you see in the picture here. So capillary refill, the pulse. Dr. Schechter's already talked to you about flexor extensor functions, and are they involved as well? Ligaments. And then we can never miss compartment syndrome. So obviously with crushing injuries, we always want to evaluate the hand and forearm for compartment pressures and assess whether we have an issue with compartment syndrome or pressures. So, oftentimes it's a mixed bag, and, we have to deal with a fracture, but we have other soft tissue injuries to account for. And I think soft tissue injuries may be the subject of another lecture down the road. One of the things with hand fractures, it's amazing how little a fracture can be displaced and how much that displacement causes in digital rotation. So you always want to look at the digital rotation of a hand and somebody who you suspect a hand fracture in. And you can see the picture here, you see a nice cascade of fingers as somebody makes a fist, as opposed to this, any fracture with any displacement, you can see that you have rotational deformity or scissoring, as we call it. And this is indicative of a hand fracture or any kind of a bone fracture in a finger, in this case being the middle finger. So we've evaluated our patient, we've assessed the patient, we've done our physical examination, and then obviously if we're suspecting a hand fracture, we want to get x-rays of the hand. Oftentimes we get 3 views. We get a AP, a lateral, and an oblique view of the hand and the wrist. Should we be considered, should we be thinking of the wrist fracture as well? So you want to look at the bone quality. The one thing in hand fractures is that can be interesting is you can have a hand fracture through a bony lesion, as you see here. So there are a variety of hand tumors, which again are not today's topic, but you can get an enchondroma or some type of a hand lesion that you have a pathologic fracture for. So you want to be aware of that and pick those out if you see them. So you want to make note of the fracture pattern and the fracture alignment. You want to kind of assess what you're up against on the various x-rays that you get of the hand. So as I said, we're going to start distally in the hand and then move proximally. Distal phalanx fractures are by far the most common fractures of the hand. Most of these happen and they are treated conservatively and they don't require any type of surgery. They're usually the result of a crushing injury, getting your car slammed in the door, hitting it with a hammer, and they can be accompanied with soft tissue disruption. The one thing to always be aware of phalanx fractures is oftentimes they are accompanied by a nail bed disruption or a subungual hematoma. So a patient who comes in with a distal phalanx fracture oftentimes has a hematoma under their nail bed, which needs to be compressed to drain that hematoma to preserve the nail bed structure. So what kind of fractures can we have in the distal phalanx? Here you see kind of like a transverse fracture of the thumb distal phalanx, which you don't see that often. And again, they can become crushing injuries, which oftentimes don't need anything. But the two ones that I wanted to point out here are bony mallet injuries and bony jersey injuries. And these are very, very common injuries that are easily diagnosed and easily treated should you see them. This just shows the variety of fracture patterns of the distal phalanx. With these crushing injuries, there's oftentimes very little displacement. As you see here, a lot of times the tuft is just pulverized into numerous pieces, or you can have a transverse fracture down the shaft. And then again, as I said earlier, not very common, but sometimes you can have a displaced transverse distal phalanx fracture through the heart of the distal phalanx. As I mentioned, most of the treatment of distal phalanx fractures is conservative. There's a variety of different types of splints you can use, and no one splint is better than any other splint. It's just immobilizing the last joint of the finger or the distal interphalangeal joint. It's really, really important when you're treating a distal phalanx fracture, and I can't underscore this enough, is you never want to immobilize the PIP joint for any reason. The PIP joint immobilized for a week or 2 or 3 or 4 will completely shut down and never move again. So you just only want to immobilize the distal portion of the finger when you're dealing with a distal phalanx fracture. Now, you can get, if, as I mentioned before, if there's any question of the integrity of the bone, you can always use a very small K-wire, an 18-gauge needle to put percutaneously through the finger, which I'll show you here in a second, to stabilize the bone and or the DIP joint if needed. I've already mentioned the drainage of the hematoma. And again, a lot of these distal phalanx fractures and injuries are accompanied by a nail bed injury. And again, beyond the scope of today's talk, which is a completely different talk, should you want to hear me talk about nail bed injuries, but removing the nail plate, examining the nail bed is very, very indicated in these type of injuries. This just shows you a simple K-wire fixation, which if you ever need to do any type of fixation in distal phalanx is all you need. Really just a 0.035 millimeter K-wire down the middle portion of the phalanx to stabilize it through the distal interphalangeal joint. Now, bony mallet fingers fall under the category of just distal phalanx fractures, and these are very, very common. And you'll see patients come in who've had injuries to their fingers. And it's usually either a forced versus a hyperextension with a dorsal lip fracture. Oftentimes these come with no fracture, and people come in with a mallet deformity of their finger, and you don't see anything on x-ray. And the treatment of that is very simple. It's just splinting for 8 weeks, as I'll tell you. But the management you got to think about a little bit more carefully when we're dealing with little fragments of bone, as we see here. The top picture is just a very tiny fragment of bone versus the lower, more significant bony mallet injury where you have subluxation of the entire distal phalanx volarly. Now, as with everything else in hand surgery, there are classification systems, and I'm not going to get into excruciating detail about this, but you can see type 1, where you have either no bone or a very small avulsion fracture. Type 2, where you have a laceration. So the reason you have a mallet finger is because it's a sharp cut down through the terminal tendon substance. A type 3, where you have a loss of skin or an abrasion where you lose that terminal tendon to the bone. And then you see the variety of type 4s with the transphysial fracture where we see in a child versus ones that have either 20 to 30 or 40% of articular involvement versus greater than 50% of articular involvement. When you get to the ones down here in the type 4s, it really depends on how much of the articular surface is involved if you need to fix it surgically. Now, in the world of mallet fingers, I would say that greater than 90% of mallet fingers can be treated conservatively simply in a splint. Even some of these ones with these big bony fragments can be treated in a splint. Now, once you reduce the fragment simply by putting the finger in an extension and putting a splint on, if you were to take an x-ray, you just want to make sure you have good approximation of those bony fragments to allow healing to occur. Now, this example that you see here may be an example of one that may require surgery, because you can see that it's a very large fragment, and then the volar tip is sublux down, and the ability to get that reduced may be nearly impossible. So as I mentioned, the type 1s, the limited ones, as you see here with a minimal bony fragment, is splinting for 6 to 8 weeks. I usually tell patients at least 8 weeks. This is around the clock splinting. The splint is not removed. They stay in it all the time. If they take their splint off, they have to protect their finger, rest their finger on a desk when they take it off. They can't take a shower without a splint. You want to avoid any movement at all to that distal fingertip, or you're going to have to take a step back and restart the clock of healing. On the ones that are more significant, there are a variety of different techniques we can use to fix these. Oftentimes if it's an open injury, you can see in this, you can make a zigzag incision. I'm a big fan of any type of hand surgery. We tend to make these zigzag type incisions. We can get down to the bone, place a K-wire through the bone, reduce it, and then put the K-wire back into the middle phalanx. These cartoons make it look pretty easy, but getting a K-wire down through the heart of the distal phalanx can be difficult. And then once we can reduce it, that can be simply enough, or we can use a smaller wire or some suture tape and a button to re-approximate that fragment. Now, a lot of these mallet finger injuries are fixed. The patient has minimal movement, and it can become painful. And if that's the case, we have to move on to doing just an arthrodesis or doing a fusion of that joint. So that's mallet fingers. I'm just going to take a pause because I want to make sure that I'm not moving through the topic too quickly. And if anybody has any questions so far, please let me hear them.
Yeah, Mugisha, do you want to ask if anybody has any questions?
Yeah, so far I have received none, and if we have anyone want to speak something.
Great.
I had a question, Dr. Scott.
Yes.
Previously, you said you could just.
Oh, sorry.
Hello?
Yes.
Yeah, sorry. Yeah, previously you said you could immobilize sufficiently with just one K-wire. Do you anticipate any deforming forces? Is one K-wire enough, or do you have to like crisscross K-wires?
Yeah. So that's a great question. And so that principle of crisscross K-wires and deforming forces is usually the principle of all hand fractures except for distal phalanx. You know, if it's almost impossible to get two crossing K-wires through the distal phalanx properly into the middle phalanx, which is the one issue. But usually the fixation with one K-wire is enough. Now, having said that, after you place one K-wire through the distal phalanx and into the middle phalanx, if you have any deforming or rotational problems at all, you can always place another obliquely oriented K-wire through that joint to further stabilize it. But in my experience, usually one K-wire is enough. So that's a great question.
Awesome. Thank you so much.
So moving on to the other side of the distal phalanx. So we just talked about the terminal extensor tendon going to the distal phalanx, which allows us to extend our finger. Now I'm going to talk about a fracture that involves the volar flexor tendon that attaches on the distal phalanx that allows the tip of our finger to flex. So these are a little bit more complicating injuries. So these are a little more difficult to fix. But one that you should be aware of is called a jersey finger. And a lot of these injuries occur when you get your finger trapped on something and you have a forced flexion of the finger. And what happens is the flexor tendon can, as you see on the cartoon here in the top right, can snap off. Now, again, everything in hand surgery has different types. And I don't know that you need to get wrapped up with all the different types here, but they all have a different meaning. So for instance, a type 1, you can see the flexor tendon, which the end is right here, has broken off with no bone and has gone through the sheath. And here it is way back here in the palm. A type 2 has come off and now it's trapped up here at where the FDS tendon inserts on the middle phalanx. And then a type 3, which is in our realm today because of fracture patterns, has a piece of bone that comes off with the tendon from the distal phalanx, okay? So a type 3, which we're going to focus on today, has an attached bony avulsion, and oftentimes that bony fragment, the good news is the bony fragment keeps it from traveling all the way back into the palm, and it gets hung up in the A4 pulley, which is nice. It makes it a little bit easier to treat. Now, to treat these can be a little tricky, and the treatment plan is really, because it's hard to get an intraoperative photo to show everybody this, but I'll just show you this via with a cartoon. Is I make my volar zigzag incisions as I showed you before. I find the tip of that tendon, and depending on how much bony fragment is there, it's usually so small, as the last person asked me a question about putting K-wires in here. So usually you can just take a piece of suture wire through that bony fragment, through the nail, and do a button, sew over button to keep that piece of that fragment attached to the bone. Now, you can see the volar aspect of that cartoon. You could do like a like kind of a crisscross suture pattern, grab a lot of that FTP tendon, and then take an 18 gauge wire or a K wire and pass it through the bone, and then pass your sutures through there and tie it over a button, as you see in this cartoon. It's very, very difficult to treat these after 2 or 3 weeks if somebody comes in, because the tendon retracts further and further, and it's impossible to get the tendon back to where it normally asserts on. So finding this injury early and getting it fixed is the key to success. And I have to tell you that even with fixation of this, patients' function at that distal tip usually remains very stiff or very limited with this technique. So again, this is called Jersey finger, and it's usually from grabbing onto something, holding it tightly, and having the tendon pull back from the bone. Distal phalanx fractures, it's interesting because I think you don't need to get a lot of x-rays to show healing of distal phalanx fractures. They oftentimes take a very long time to heal, and I don't generally wait for bony healing on distal phalanx fractures to allow patients to start moving. Many of these fractures go on to asymptomatic fibrous union. So even though the fracture, the x-ray doesn't look great, there's no reason to keep on splinting these patients for beyond 4 or 6 weeks. Like, don't splint them for 8 weeks or 12 weeks, because their finger will never move again. So I'm going to move on to middle and proximal phalanx fractures. There's really a lot to say more about distal phalanx fractures than that. Is there any questions about distal phalanx fractures?
I have a question, Dr. Scott.
Please, yes, please.
With regards to distal phalanx fractures versus middle and proximal phalanx fractures, which is more forgiving in terms of immobilization and back to rehab? Like, which one would you said, like, when you try and immobilize the distal phalanx, that you shouldn't touch the proximal interphalangeal joint, because it's not very forgiving in terms of movement after it's stiff for a while. So what are the timelines? Like, I know it's 4 weeks, as you said, for the distal, but what about the middle and proximal? Is it similar?
Yep, so it's similar, and we're going to dive into the middle and proximal phalanx right now. But to answer your question, the distal phalanx is way more forgiving. As we'll talk about right now, middle and proximal phalanx fractures are not forgiving, and the same principles hold true with regard to you know, the fracture patterns and how we're going to either immobilize it or fix it. In my mind, every time I see a phalanx fracture, I think, okay, do I want to immobilize this and let it heal? Or do I want to open this and fix it and then get them on to rehab faster than just immobilization? So with all fractures, it's always a balance of how you're going to treat it. Because, you know, we can always get these, the fractures will always heal. So in your mind, you've always got to be thinking about getting it to heal and get the patient moving. That fine line between getting them moving as fast as you can, but not too fast, because with any hand fracture, you're going to have a lot of stiffness after the treatment. So great question, and that helps me move into this next topic, which is actually middle and proximal phalanx fractures. So you can categorize these as extra or intra-articular. The extra-articular ones are easier to manage. The intra-articular ones are very, very difficult and are prone to a lot of stiffness. The extra-articular fractures, the ones that are not displaced or minimally displaced, can be treated with a splinter or cast. As I just said, adequate reduction is the key, because if you don't adequately reduce the bone, you're going to have an imbalance of your extension and your flexion on your mechanism of your hand, and that's going to affect your motion. When you have a displaced or an unstable fracture, that should be treated with either closed reduction and percutaneous pinning, or open reduction and internal fixation. So at the outset, I will tell everybody that opening a finger fracture and fixing it makes a very nice X-ray. It shows a nicely reduced fracture with a plate and screws. But I have to tell you that, again, you have to balance. Do I want to just reduce the fracture and pin it percutaneously? That doesn't create as much scar tissue as making a big incision, a dissection down to the bone, and putting screws into the bone. So while open reduction may give you better fixation, it also has a higher rate of stiffness postoperatively. And we'll talk a little bit more about that as we move forward. So as with any other fracture with the phalanx, you see the middle phalanx here. This is from our AO surgery guide, just to demonstrate the different types of, middle phalanx fractures come in all shapes and sizes, as do proximal phalanx fractures you see down here. And the fracture pattern and the stability of the fracture pattern leads us to either treating it with immobilization or having to do surgery. And again, simplistically, if the fracture pattern is stable, meaning that it's not moving, the finger is in good rotation, then just treat it in 4 weeks with immobilization. If the fracture pattern is oblique, like you see here, and it can move, then you probably want to consider treating it with some type of fixation. And here's a pretty typical proximal phalanx fracture pattern. You see the patient who has what we call like a swan neck type deformity of the proximal phalanx. And this here is the base of the proximal phalanx and the distal portion of the proximal phalanx. And why does this happen? Well, because the intrinsic muscles are holding the base stable, and the extension of the finger is pulling this distal portion of the phalanx in a retrograde fashion. So this is called apex volar. So the fracture is volar. So apex volar is what we call this. So intra-articular fractures are very, very common and very, very difficult to treat. We have in hand surgery, we can also call these pylon fractures. The phalangeal fractures that are non-displaced can be buddy taped with early range of motion. And as I already mentioned, the displaced fractures, you can have a dorsal central slip avulsion, which we'll talk about, a volar plate avulsion, or a pylon type fracture. And again, I'll show you some examples of pylon fractures of the condyles. They're incredibly difficult to reconstruct, and you have a lot of different options. And you can either open these, or one topic I'm not going to get into today a lot, but I'll just mention right now is any unstable hand fracture that you cannot fix with pinning or opening. You can always put you can always even use a external fixator. You can actually make an external fixator by placing K-wires on either side of the fracture and just putting rubber bands between the two just to hold the fracture stable to allow the fracture to heal. So here's a good example of when I see a fracture like this, I look at this and I say, wow, how would I even manage this PIP joint dislocation fracture? Well, the bottom line is I can't put pins in there. I can't put screws in there. So there's actually, for a very difficult fracture, there's a very simple solution. Simply just putting a blocking K-wire into the joint that keeps the finger, the joint congruent, meaning it keeps the finger in the joint at the PIP level to allow it to heal, and to allow it to heal with a good joint space. And it just blocks the finger from extending to further displace that fracture. So as I stated, the phalangeal fractures can be oriented transversely, obliquely, they can be spiral or comminuted. Non-displaced can be splinted, buddy taped, early range of motion. Even some of the displaced fractures, if you can reduce it and it's stable, you can still cast that for 4 weeks and allow it to heal. And then the displaced ones require surgery. And again, depending on what you're comfortable with, you can just put percutaneous pins, you can open it or put an external fixator on those fractures. So here's an example, right? So as I said in the early part of my talk, this is part of the examination of the patient. So, I look at this x-ray and I think all of us would agree that this is a transverse kind of oblique fracture through the proximal phalanx, and it's displaced. I mean, I don't think any of us would accept that type of displacement. You can see on the lateral here that it's apex volar as well, as I already stated. So again, you can look at this and say, wow, I can open that and put plates on it, but 99% of the time for me in my practice, I will reduce that fracture and I will simply put two crossing K-wires through that fracture to stabilize it. I'll keep those pins in, and this goes for any fracture that I pin. I'll keep them in for no more than 4 weeks to allow healing. I will then pull the pins out in clinic and get the patient moving as fast as possible. So here's an example that, based on that last example, I don't think I can get K-wires into this, crossing K-wires to stabilize this, what we call a more oblique fracture. This is a very unstable fracture pattern. And so then we have to make an incision and reduce that fracture and then put screws through that fracture. Now, this example, I show 3 screws, but you could fix this fracture with 2, as we call them, lag screws through the fracture pattern to make this fracture stable. And so the patient's rehab of this, the one benefit of the screws is that you cannot move this patient early, right? They've got pins coming out of their skin and you cannot start movement. So they're in a splint for 4 weeks. This patient, for instance, you could put lag screws, you can close the incision, and you can start moving this patient within a week. So gentle range of motion within a week to get them moving. So they improve their range of motion. Now, as I've already mentioned, these condyle fractures are very, very difficult, and they're very, very hard to manage. You can have, and again, as everything else in hand surgery, there are a variety of different types of these. But the ones that are stable, if you get one that's stable, hopefully, then it's easy to treat. It's the same management. You can just splint these and let these heal. But if you have any type of displacement at all, and this one is not that difficult, you could imagine reducing this and putting either a couple screws across here or a K-wire. But these ones are very, very difficult to treat. These bicondylar ones that are comminuted, they lose height, and they oftentimes go on to stiffness and arthritis of that joint. So those are middle and proximal phalanx fractures. What questions do you guys have on these type of fractures?
Anyone with a question? You're welcome.
I have a question if nobody else has a question. How do you,
Okay, go ahead.
how do you stabilize the intra-articular components of the of fractures of the middle and proximal phalanges?
Yeah, so good question, Dr. Schechter. So, you know, it depends on the amount of comminution. So if the one example I showed you is sometimes if it's so bad, you can't stabilize it, then what I do simply is I will put K-wires. So let's just say this is a PIP joint fracture that's unstable. I will put a K-wire both in the proximal and middle phalanx, and you can make a little external fixator just out of K-wires, and you can stabilize those with some rubber bands and stabilize the fracture. If there are pieces like, so since I have this slide up on this grade 2, if this is interarticular, I could stabilize this with a couple K-wires. But the last thing that you want to do in interarticular unstable fracture is open it, because there's nothing to do inside there. There's too many bone fragments, and you don't want to jeopardize the bone, the soft envelope over those fractures. So I think your only options really are external fixator versus fracture fragment specific pins.
Thank you very much.
Was there another question that came up? I'm sorry if I missed that. Okay, so we're going to move down the hand. And so, you know, phalanx fractures, again, this is not a big femur fracture or a tibia fracture, but it's interesting. The small, I think in my world of hand surgery, these smaller bones are actually more complicated to fix than the bigger bones in the body. Now, moving on to metacarpal fractures, I think globally, metacarpal fractures are fun fractures to fix, and they are a lot more forgiving than the phalanx fractures. That previous question that was given to me, this holds true. The finger fractures are very unforgiving. Even when they're not intra-articular, they cause a lot of stiffness of the finger. Metacarpal fractures are a little bit more forgiving. You can treat a metacarpal fracture and get a patient onto moving a little quicker and get them better hand function. So as again, like with anything else in hand surgery, you classify your metacarpals based on the location. So is it in the base of the metacarpal, the shaft, or the head? The type of fracture, is it transverse? Is it oblique? Is it spiral, or is it comminuted? And then also take in consideration multiple metacarpal fractures or fracture dislocations, which can be tricky, and I'll show you some of those as well. I'll start with the thumb. The thumb fractures are very common, and you know, the thumb is 40% of the function of our hand, and so we pay particular attention to any fracture that involves the thumb. Now, because of the joint of the thumb has excellent mobility, so extra-articular fractures of the thumb are very easy to treat and have a great prognosis. And although we still want to get good anatomic reduction, the thumb will accept actually even poor reduction in a lot of circumstances with good outcomes. So an extra-articular fracture can simply be treated with closed reduction and mobilization in a thumb spica cast or a splint for 3 to 4 weeks. We utilize, again, percutaneous pinning or open reduction for widely displaced or unstable fractures. And as I said, you can accept as much as 30 degrees of angulation and as much as 3 to 4 millimeters of shortening are acceptable in the thumb with actually no limitations at all. So it's pretty amazing. So the intra-articular fracture of the thumb, and I think you all probably heard this term called the Bennett's fracture, sometimes referred to as a Bennett's fracture dislocation of the thumb. And it has a very predictable pattern, as you see over here. The bone fragment stays attached to the anterior oblique ligament and stays in position, and the metacarpal then becomes sublux from the trapezium proximally because of the pull of the abductor pollicis longus tendon. And it causes this really reproducible fracture pattern that you'll see in many patients. Is there a question? Oh, sorry. As opposed to the Rolando fracture, which I'll talk about, which is a little bit more challenging, but it's more like a two or three bony fragments, and it's very, very unstable. So the pathophysiology, as I just mentioned, is because of this consistent pull of the abductor pollicis longus and the adductor here. So the fracture fragment stays in its place because of the ligaments, and the bone itself comes off and goes proximally. And again, this is a very, very, very common fracture pattern. And if you see this, easy to treat. So if you see this in your practice, you can utilize what you know about the pathophysiology of this fracture and put pressure on this fragment and reduce the bone, as you see in this picture here, and simply put in some K-wires to stabilize the metacarpal to the remaining fracture fragment of this Bennett's fracture. So you could do this under fluoroscopy. You don't even need fluoroscopy, but you can actually feel this reduction with your thumb. You place pressure on the base of the metacarpal. You can pop it right back in place and stabilize it with K-wires. Now, I will say that unlike some other reduction maneuvers, because of the deforming forces of the tendons, once you do this, it needs to stay there with some type of fixation like K-wires. It won't just pop in there, and you can't pop this in there and then put somebody in a splint. It won't stay there. It'll keep pulling it back. So this does require fixation. So you see, and this, I put this picture in here. The patient usually shows up with a lot of thumb swelling and pain. And this one is a little harder to see, but you can see the fracture fragment right here in place. And this bone hasn't come off as much, but this is the fracture fragment here. You see how we place longitudinal traction on the thumb. We push in the base of the thumb and then place K-wires. And you can put K-wires anywhere. You don't even need to put a K-wire through the fracture fragment itself. You can simply put in a K-wire from the base of the metacarpal into the trapezium, and or from the base of the metacarpal into the second metacarpal as well. As long as you stabilize this first metacarpal, you'll keep the bone in good opposition to that fracture fragment. And again, this just shows it in cartoon fashion, showing how we stabilize it by putting an oblique K-wire into the trapezium. As I said, you could place it through the fracture fragment or not. You can put these crossing. Any of these techniques work fine for your K-wire stabilization of the Bennett's fracture. And I spend a lot of time talking about this because of all the hand fractures that you see, This is a very common one that you see. It's a very common one that you can treat, and the outcomes of this are great. The patient has excellent range of motion as long as you reduce the bone back into that trapezius, that metacarpal trapezial joint. Now, if you're in the operating room and you absolutely cannot reduce that fracture fragment, you've got to open this fracture. Because like any other hand fracture, if you cannot reduce a hand fracture in a closed fashion, something is blocking your reduction. And most of the time it's just soft tissue. Or if it's a fracture that's a week or 2 or 3 old, maybe it's some scar tissue or bony healing in the fracture, which is why you can't reduce it. So you need to open that up. So you can make an incision along the volar radial border of the thumb metacarpal, right between where you see the thenar skin and the dorsal skin, that hair-bearing skin. You can make an incision along there, expose the fracture site, just very carefully clean out, debride that fracture. And then if you clean it out properly, you'll be able to get great reduction. If you still can't reduce it, you have not cleaned out your fracture enough to get it reduced. You open it up, you clean the fracture site out, and then you place your K-wires to allow you to get beautiful reduction. And this is what you should see in the operating room. You need to reestablish that beautiful joint, and it's very, very easy to do. So as I mentioned, the other part of thumb-based fractures, so you have the Bennett's fracture, which is the one fragment, and then you have these what we call Rolando's fractures, and these could be in a Y or a T-shaped fracture fragment, and there's just a volar component to these, and these are a lot more challenging to fix, and sometimes you can fix these percutaneously, but oftentimes you have to open these up and just fix these in a fracture fragment specific fashion, i.e. you can put a plate on these to hold these, you can put a screw through a fracture fragment here, but these are very, very difficult to treat. If they're so bad and this whole base is comminuted, the treatment becomes easy. I just crack the thumb and I'll put 2 K-wires to the second metacarpal just to hold it out to allow this comminuted area to heal. I don't put any screws or pins through that area because there's nothing to take to it. So I just let it heal naturally to get the best outcome we can get. So that's the thumb-based fractures. I'm going to move on to the other base metacarpals. Is there any questions about these thumb-based fractures? And I'll just say,
I was just going to say, Scott,
Yeah.
maybe at the end we can have people present cases that their own cases of hand fractures that they've had problems with, and say what happened, and then you can make some comments.
oh, I would love that. That would be great. Thanks, Bill. So, unlike the thumb, the base fractures of the other digits of the hand are very easy to treat with excellent outcomes. Most of the time, these can be treated with simple immobilization, and they usually involve the small and ring metacarpals. A couple of things that I just want to make you aware of. When you have a base fracture of the 5th metacarpal, oftentimes you also have an issue with the hamate. So you want to look at your x-rays very carefully to see if there's any fracture of the hamate. Now, knowing that is important because depending on the severity of that fracture, hamate fractures, if they're slight, they don't need anything. But oftentimes you can have a bigger piece of hamate that you need to fix. We call these in terms, these we call the reverse Bennett's, which are opposite of the thumbs. We call them the reverse Bennett's. And diagnosis can be difficult. And sometimes we need to get different x-rays or a CT scan to see these better. But with these fifth finger, lesser digit injury, if it's somewhat displaced, simply putting.
Let me interrupt for a minute. Somebody's got their microphone open and we can hear a child in the background. Everybody mute their microphone. Lisa, you want to take care of that?
Great. So in this case example, so we call this a reverse Bennett's fracture. So here's the thumb over here, right? Here's the fifth metacarpal, and the metacarpal is fractured, but it's also dislocated proximally. You see the fracture fragment way up here. So again, we could just reduce this fracture, place oblique K-wires across these fragments into the carpus of the hand, 4 weeks, and they're easily treated. Now, the shaft fractures are fun. They're a fun surgery, and they come in a variety of different types. They can be transversely oriented, oblique, spiral, or comminuted. Again, we want to first identify the fracture pattern. Then we want to look at the fracture and say, okay, is it non-displaced or minimally displaced? If so, and if it's stable, we can treat them in a short arm cast or a splint. The ones, again, that are unstable or displaced, we need to figure out a way that we're going to stabilize that fracture. And again, the same things as the phalanx fractures. Either we reduce it closed and it's stable and cast it, we can percutaneously pin it, or we can open these fractures and fix them with plates and screws. So here's a shaft fracture. Again, I think all of us would agree this is displaced. And this is interesting because you need more than one view. If you just look at this view and say, well, it's mildly displaced. Well, if you look at this more oblique or lateral view, it's markedly displaced. The other thing that we want to notice on our patient, because of that, has a significant rotational deformity of the finger. So we need to open and fix these if the rotational deformity leads to digital overlap. So otherwise noted as scissoring of the finger. So as much as 5 degrees of malrotation of the metacarpal can cause 1.5 centimeters of digital overlap and flexion. So as I stated earlier in my talk, even ever so slight a displacement in the metacarpal can translate to a lot of rotational deformity in the finger. So you got to look at the x-ray and you got to examine the patient to see how much overlap they have in the fingers. Unlike the thumb, you cannot accept fracture shortening of the metacarpals in the hand because, again, the tendon imbalances that we see. And then we also have fractures with greater than 20 or 30 degrees of angulation. We want to fix those fractures as well because they're far too displaced. So here's an example. You may look at this fracture and say, well, that's a significant fracture here on the 5th metacarpal. It's a spiral oblique, but it's not particularly displaced and there's no malrotation. So if this is stable, you could simply cast this patient, allow it to heal, and then 3 to 4 weeks later, you have good motion. And what you see here is perfect motion. So everything in hand surgery, the outcomes are measured by this picture. It doesn't matter how good you can make an x-ray look, but if you have our goal is to get the patient back to full range of motion of the hand after any type of intervention that we do. So as opposed to this fracture, is simple pinning of the fracture. Now, what you'll notice here, based on the bend of my K-wires, I approach this in a retrograde fashion. So in the proximal phalanx, I usually go antegrade. So I usually place my K-wire at the base of the proximal phalanx and I move distally. In the metacarpal fractures in the operating room, I will reduce the fracture and then I will hand place my K-wire at the metacarpal head. I will find the perfect position and then I will carefully move that K-wire down the shaft while I reduce the metacarpal fracture. Now, this is a lot easier than it looks. It's a lot harder than it looks. It's not as easy as it looks, but with some practice, you don't want to force these K-wires into the metacarpal canal. I oftentimes will just take a K-wire driver and I will hand place these. And once I'm into the canal of the bone, I will drive this by my hand with a K-wire driver down the medullary canal, and the K-wire just finds its way down the canal versus using power or a K-wire driver that will oftentimes push the K-wire out of the cortex of the bone. So there's a lot of finesse in this, and it's a lot of fun once you get the hang of these fracture fixation mechanisms. It's also fun to do cases like this, exposing the fracture. You can get, if you have to open the fracture, you make an incision directly over the metacarpal, you dissect the eccentric tendons to the side, you come right down to the metacarpal itself, you expose the fracture, you carefully and meticulously clean out all the debris from the fracture site. You use whatever type of clamps that you can use to get reduction, and then you simply place 2 or 3 screws through the fracture pattern, and it makes a very nice, beautiful postoperative X-ray once you get good reduction of those fractures. Now, with the ones that you can't put screws across, so in this case, this is a transverse fracture that you see here, and we can't put simple lag screws across that. So there are a number of plating systems that we use in hand surgery, and there's, in my mind, no one better than the other. But simple plating technique, meaning you want to place at least 2 to 3 screws on either side of that fracture. So in the same technique as the lag screws, the same incision, the same exposure, you get good exposure of your bone. You could reduce this with a couple K-wires to keep it stable, place your plate on the bone, and then place your screws on either side of the fracture to provide good stable fixation of that fracture. As with everything else in hand surgery, post-operative motion is critical, so even when somebody has a metacarpal fracture, I will just splinter cast them so you keep their fingers free to move. You don't want to cast or splint the entire hand in these patients because everything will get tight and closed down. So you want to work on their IP motion, their metacarpal phalangeal motion, their CMC motion, and you really want to try to prevent any kind of web contracture with immobilization. And with regard to strength, we work on their grip and pin strength in hand therapy as well. So metacarpal shaft fractures, again, mobilization for 3 to 5 weeks. I always monitor them. So if I can go shorter, 3 weeks is fine, but usually it's around 4 weeks. Unlike the hand fractures, I clearly stated that hand fractures I don't like to open because they get really stiff. Metacarpal fractures, I would open if you want to and if you feel comfortable, because if you open and get good internal fixation, you can get them moving with a removable splint up to 1 week postoperatively and get their range of motion back much, much faster. Now, with regards to metacarpal fractures, I'll finish with neck fractures, and these are otherwise known as boxer's fractures, and these can be transverse, comminuted, non-displaced or minimally displaced ones can be treated closed. They are rarely associated with malrotation, and you could reduce these, but it's rarely successful. Oftentimes they just fall off, but the beauty of these fractures is that you could have these fractures, you can accept 20 to 30 degrees of angulation and patients will still maintain excellent range of motion as long as they don't have any rotational deformity. as I just mentioned, the indications for fracture, it really depends on the degree of apex dorsal angulation. So one school of thought is, if you look at the index, long ring, and small finger, as you can see, you can accept only up to 10 degrees of displacement in the index, 20 degrees in the middle finger, 30 degrees in the ring finger, and we can accept up to 40 degrees of angulation in the small finger. This remains controversial in the hand surgery literature, but I will tell everybody that I've seen up to these degrees and people do just fine. So again, you want to balance fixation versus just letting them heal and immobilizing them based on how you want their motion to be after treatment. Here's a good example of a boxer's fracture that is fairly non-displaced. This, you know, you could treat this one. You could treat this one either way. Now, this one, you look at it, well, there's nothing wrong here. This one kind of surprises because there is some rotational deformity in this finger. And so we had to reduce it in the operating room and place, again, a couple K-wires across that to fix it because of the rotational deformity. But 90% of the time, I use this as an example, but 90% of the time, these are healed just fine with cast immobilization. I think this picture is great because it underscores a lot of things we've talked about in hand surgery. We're always balancing fixation and treatment on postoperative function of patients. Now, and this picture shows it, and this is what I always tell patients when I see them, when I'm consulting with them on their case. This is why the hand is so hard to fix. This is a cross section you see through the through the metacarpal, the proximal phalanx, the tendon, and the skin. There is absolutely zero room for error here, which is why with bony injuries, with tendon injuries, there is nowhere for that scar tissue to go not to affect your outcomes. And so everything you treat in hand surgery, in the back of your mind, you're always wondering, okay, how can I treat this and get the patient moving as fast as I possibly can? Because this is all going to turn into one big scar ball after, if you can imagine, a fracture through here, a fracture through the metacarpal, a fracture through this joint. It's all connected here. And this is why everything shuts down after hand surgery and gets so stiff. So as to kind of wrap up my thoughts on the metacarpals and carpal bones. So again, you want to start range of motion as soon as possible, hopefully by 3 to 4 weeks after non-operative treatment. Percutaneous pinning, the upside is that there's no operative dissection, but you cannot move these patients again until they heal, which is 3 to 4 weeks. The one benefit I could say, I think, primarily in metacarpal fractures, is I open these more commonly nowadays to get them fixed and get these patients moving about a week post-operatively as fast as possible. So with that, I'll pause, and that encompasses our phalanges of the hand and metacarpals, and it stops at the carpus. And I think if we have cases, I don't know, Dr. Schechter and Mugisha, if you guys want to stop, I can entertain questions, or we can look at some cases at this point.
Mugisha, we'll leave it up to you to moderate this. Are you there? Well, let me ask the group. You guys have any? Are you guys managing hand fractures in your practice? If so, have you encountered any difficulties, any outcomes that you were not happy with? How did you manage it? Maybe we can get some advice from Dr. Hansen about what the different alternatives are.
Yeah, and I would, if anybody has any X-rays or hand cases, I would be more than happy to give my comments on them. I would love that.
Okay, well, it looks like there's a question in the chat. Let me look at that. There's a question, what's the proper management of an MCP joint of the thumb after multiple reduction failures?
Yeah. So if you cannot reduce it in a closed fashion, the last thing that you want to do is reduce it and pin it to keep it in a certain place without a good reduction. 100% of the time, if you cannot do it after multiple failures, there is something, the ligament, soft tissue, a tendon sometimes blocking your reduction. So with the MCP joint to the thumb, you can open it. I think that, in fact, I've got in my mind, I can think of a pediatric case that we did at UCSF recently where a colleague of mine had that exact case. And they opened it. You can open these either dorsally or volarly. They opened it dorsally to see if they can get it reduced, and they still couldn't get it reduced, and had to then open it volarly and found that the flexor tendon was trapped inside there. So that's a very good question, and that's probably in all of hand. Something that happens more frequently is the inability to reduce the thumb MCP joint. So you have to open it, and you have to keep searching carefully to see what's blocking the reduction.
So let me ask you a question, Scott. If you're making if you're approaching the MCP joint of the thumb volarly, you've got the thenar wad there. How do you approach it? You're making a zigzag incision, and then
yeah. So basically, Dr. Schechter, volarly, I go straight volar and the thumb, and I don't know if anybody can see me demonstrate on my screen, but I will go zigzag down to the base of the thumb. It doesn't matter which way you zig or zag. I definitely would not make a straight up and down incision. I would start at the interphalangeal joint, and I would come down to the MCP joint, and I would do just basically a triangle, and I would open it up that way down to the joint.
Now you've got the fibroosseous tunnel there with the flexor pollicis longus tendon running through it. So how do you preserve? Oh, I see. So in this case, the fibroosseous tunnel was disrupted, and then the tendon sort of herniated into the joint.
That's 9 times out of 10. That's what it is. So yeah. So I would go in there, and it's interesting because these cases, they don't look like a textbook. Everything looks jumbled and is a mess. And if you see the fibroosseous tunnel, then you would incise it and open it, and you would gain access down to the joint that way. So you'd have to come through the volar plate as well. And oftentimes, I should take my comment back. Probably more commonly, the volar plate is what's blocking your reduction and not the tendon. It secondarily can be the tendon, but it's usually the volar plate. So what has happened, and again, I commend that question about the MCP joint reduction, because the volar plate will pull off either proximally or distally from the bone, and then it'll flap into the joint, blocking your reduction.
Okay, anybody else have any other difficulties that they've encountered?
There is a question about prognosis on the same concept, and as he tries to answer that, there is also a question about, does age determine which method of reduction between ORIF and open reduction? Does age limit certain type of fractures to be treated otherwise?
That's a good question about age. You know, I think that we are so good now at managing hand fractures that, you know, I think the patient's age wait, I mean, is it the patient's age or the fracture age? I guess the first question that I have. Because
Is patient age.
patient age, okay, because obviously the fracture age also comes into play because as a fracture gets longer out, the chances of having to open it is more and more because of the fracture callus. Patient's age, no, I think that the key treatment is good reduction and good fixation of the bone. And I think that you want the best functional outcomes. And as you know, I don't think it's right to say, well, if the patient's 80, we're just going to leave this malreduced bone because they have poor function. I think you take each patient in consideration, their level of function, as I said at the outset of my talk. If a patient has a baseline poor level of function, yeah, maybe I wouldn't be so aggressive as to open a fracture and fix it percutaneously. Maybe somebody would manage internal fixation better than having pins sticking out of their skin, if that's hard to do on a child, for instance. So I think you have to take the patient factors, the patient age, the patient's medical situation all together to decide what the best fixation method, closed versus open, is.
What about there was a question about the prognosis of MCP joint fractures after reduction.
Well, good. So a pure MCP joint dislocation has an incredibly good prognosis. A fracture dislocation at the thumb MCP actually has a reasonably good prognosis, better than any of the other fingers, because again, the thumb rebounds a lot better than the other fingers with regard to range of motion, and accepts deformity better than the other fingers. The thumb doesn't need to have perfect full range of motion to be as effective as it is. I always like to use the funny situation, like I can transplant somebody's big toe and make them a thumb, which is something that I do, and they have excellent function of their hand, and the thumb doesn't even move, that toe doesn't even move that much on their hand. So the global answer to that question is the prognosis is good.
There was another question about pain management after I presume this is for, I don't know who wrote this, but I presume it's the same fracture, the base of the thumb. What about
Yeah,
pain?
well, I can speak to like general hand things, and I'm going to state the obvious here. The best pain control in hand surgery, any kind of hand surgery, is elevation. When you ever see a patient with hand injury, should you operate on them or not, they need to elevate the hand above the level of their heart after the injury for 2 to 4 days and keep it there. Having their arm in a sling is not elevation. They need to be with their arm up in the air like this on 4 different pillows to elevate it. Swelling the hand is a closed space. Swelling of the hand causes an incredible amount of pain that is not covered by any pain medication on the planet. If you've all slammed your finger in a car door and you felt your fingertip pulsate, you can imagine what a metacarpal fracture feels like in your hand with a large amount of swelling. So the best pain control is elevation, 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 and edema management. And having said that, like any other management, we give standard pain medications, and there's a lot of studies in the hand surgery world that you don't need to have 30 codeines for a hand, you need 5 or 10. So the first day or two after surgery is usually the worst. With good elevation and staying on top of your pain, you should not need that many pain medications.
Let me ask our African surgeons about percutaneous K-wires coming out of the skin. You guys have problems with pin tract infections because some of our patients live in very nice apartments and hygienic situations. And some of our patients live in places where maintaining good hygiene is difficult. So my question is, for those of you who are practicing in Africa, what about percutaneous K-wires coming out of the skin? Is that a big problem, or it's not really a problem? Anybody want to answer?
With experience from Namibia, we don't have a problem with that.
Okay, well that's very useful information.
I think that's a great question, Dr. Schechter. I think that we always, even here in the States, in my patient population, the general hospital, I worry about K-wires. It's interesting, you don't see as many K-wire site infections as you would think. And as a matter of fact, I mean, I've gone through bearing them as well, and that also is not perfect either. So you're going to see some pin site infections, but should they get infected, they're usually easily to make. They don't really happen that often.
Hello. Hello, everyone. Good evening. So for us in Tanzania, pin infection, we don't have such experiences. Most of the time, even when we put the percutaneous pinning, until the time we take them off, there is no pin site infection. That's the experience right here with us in Kilimanjaro specifically. Thank you.
Thank you very much.
Yeah, there is a question. There's a question on chat box about the use of how does the patient fare well in terms of feeling about the implant since the soft tissue is inadequate.
Yeah, another great question. Unlike other places of the body, when you put internal fixation, I would say that in general, you have to take the hardware out in a significant number of cases in hand surgery because of that very problem of lack of soft tissues. And just like that picture I showed everybody, the cross section of the hand, there's not a lot of places for that plate to be not to affect the local surrounding soft tissues. And so, for instance, in a metacarpal fracture, once the patient is healed, if they have no issues, then fine. But should they have pain or irritation of the tendon, that has to come out. And luckily, it's pretty straightforward to take it out. Now, on the hand, that's a reason not to put a plate on a hand fracture, because every time that plate will get in the way of the function of the local soft tissues. And so only if you need to do that, but that is one of the number one issues with putting a plate in a hand, is that there is not a lot of soft tissues around to provide coverage of that for long term. So again, even in the wrist fractures that we do, it causes tendon irritation as well. So when you follow the patient, they will particularly tell you maybe they're doing well, but they say, yeah, I have pain around the hardware or irritation. You need to get the hardware out. Continued irritation will cause tendon rupture.
Okay, thank you. And if you, I heard some people flashing out their microphone. They are welcome for a comment. Samuel, I saw your hand, and I think Samuel Ochung. Yeah, it says pretty much experience in Uganda. We rarely see pin site infection in most cases, with a few exceptions of very severely immunocompromised patients. Thank you.
Yeah.
Anyone else?
Dr. Scott, I have a question.
Yes.
with regards to in one of the images there, you showed that you use a driver for K wires to insert into the metacarpal. In metacarpal fractures, become metacarpal shaft fractures.
Yeah.
I saw a video of ones that were like there was a video that I saw where they pre-bend, and they didn't pre-bend, but as they inserted it through the metacarpal head, as they were driving it through into, they did the reduction, and as they were driving it through into the shaft, they bent it in the opposite direction. So if there was an apex volar fracture, they bent it. I mean, if it was apex dorsal fracture, they bent it apex volar to counter the fracture to get the 3-point fixation. Have you seen that being done, or do you have
absolutely, yeah. And that's a little bit of an advanced technique, and I like that technique. But you gotta be careful, because once you bend the K wire, you can't really spin it in a driver, because it'll be off and it'll wobble. So how I use that bend, and I like this question because I do this, is I will bend, yes, I will bend the K wire in the opposite direction, but it's then I hand place it in the metacarpal and I spin it down with a heavy needle driver down through the fracture site. But then you have to turn it so where it's opposite of the fracture pattern. So it can be a little tricky. Having said that, having done many of these, do you need to do that? I would say that I would get comfortable with just the hand technique first, not bending it, or use power if you need to, because that can be a little tricky. And I don't know how necessary actually that is. I mean, it definitely helps reduce the fracture better and hold it, but I'm not sure if it's entirely necessary to do that technique.
Awesome, thank you so much. And can you use the same, like, can you use your hand to drive the K wire elsewhere, like in other fractures of the fingers?
Yeah, so another wonderful question. And so I love percutaneous. I feel percutaneous pinning of hand fractures is a science. It's very, I think, it takes a long time to learn. So let me just take you through that, how I do that. So what I will do with any metacarpal proximal phalanx or middle phalanx, I will take the K wire with my hand. Okay, so I don't take it with the driver, and I try to put it where I take it with my hand. I put it exactly where I want it to go. I confirm the position with fluoroscopy. I then take a driver and I drive it 1 millimeter or 2 into the cortex to start it, just so the K wire is into the canal a little bit. I don't use the driver anymore then, okay? I simply use a K wire driver then to push the K wire into the canal. As I said in my talk, if you start driving it with a lot of power, the K wire will start going out of the cortex every single time. If you simply and carefully push, once you're in the canal, you push the K wire through the canal with a K wire driver, it'll follow the path of the canal beautifully, and you will have a picture perfect reduction of your fracture. I do that with every fracture in the hand. If I'm dealing with an older patient who has a proximal phalanx fracture, and I'm putting that K wire in antegrade through the proximal phalanx, I won't even use my K wire driver at all. I'll place it with my hand. I will confirm the position with my fluoroscopy. I will then just take a K wire driver and I'll push it right into the canal with a K wire driver. If you use your K wire driver too much, you go in and out, in and out, in and out of the bone. There's not a lot of bone there, and you're gonna destroy the bone. So if you just practice with hand placing your K wires in the hand, you're gonna find it to be easier and more precise with your fixation.
Thank you so much. That was very insightful because we have the same problem. We use a driver and it just goes everywhere. It just
Yes,
go
right.
out
Oh,
in,
no,
out.
and I teach my residents this every single day. And it's like a light goes off in their head when I show them this. And it's very simple. It is so hard to drive a K-wire where you want it to go on a hand fracture with power and it's spinning really fast because it's not gonna respect any margins of the metacarpal of the bony canal. If you push it through, you're not strong enough to push it all the way through the cortex. So it'll take the path of least resistance right down the pathway of the canal.
Awesome. Thank you so much, Dr. Scott.
Yes, thank you very much. In the interest of time, we have to come to an end for today. We would like to appreciate for the time and investment and the commitment that Dr. Bill and Dr. Scott have extended to us. We all agree that this was a very important talk and it has alluded us some of the very interesting experiences from Dr. Scott, and we are sure that it will also help on our experiences. The discussion was so lucrative and the talk was so fantastic. We want to thank you very much, Dr. Scott, and also we extend our great appreciation to Dr. Bill, who invited you.
Well,
You're allowed
it's been an honor.
to make some, yeah, you're allowed to make a sentence and Dr. Bill to make a sentence, then we'll call it an end and we'll plan for the next week.
Well, I would just like to say it's been an honor for me to be here today. What a wonderful questions you guys have posed me, and again, I'm happy to do this anytime. Thank you to Dr. Schechter who invited me.
All right, well, thank you, everybody. Scott, that was the best talk I've ever heard on hand fractures. The light bulb went on, so it was fantastic. I want to thank everybody for spending the evening with us. Next week, we're going to discuss extensor tendon injuries and neuropathy. So if you guys are interested in those subjects, we'll see you next week. Thank you very much. Bye-bye. Thanks, Scott.
Yeah, of course.
Thank you very much. Scott will share with us the slides.
Yes. Thank you.